Welcome to Conference Highlights, recorded in front of a live audience at an evidence-based perioperative medicine at EBPOM Conference. EBPOM are world leaders in perioperative education, so why not join us at our next meeting with a special discount for Top Med Talk subscribers. Look us up on www.ebpom, that's EBPOM.com. Top Med Talk.
Dr. Darren Flynn, who is a health psychologist from Newcastle, who's been working there to develop a lifestyle intervention for liver transplantation patients, both prior to and after liver transplant.
Thank you, Danny. Hello, everybody. Great to be here. So I'm going to talk about the lifestyle intervention for liver transplantation. First of all, I'd like to acknowledge that this is very much a team effort. This is not something I developed by myself. The LIFT investigators include Dr. Lee Ravery, Newcastle University, Dr. James Prentice, Dr. Chris Snowden at the Freeman Hospital Institute of Transplantation, and Kate Holdsworth. And this is funded by a grant from Liver North and the Newcastle upon Tynes Hospitals NHS Trust, charitable trustees. I'm going to provide an overview, first of all, the rationale. Why do we need a lift? Then secondly, I'm going to talk about the development process, because this is very much in the developmental stages of intervention development. And then give you a flavour of some of the content we've developed in collaboration with patients and the clinical team. So why do we need a lift? Context: the liver transplantation is associated with the development of new or the deterioration of existing chronic conditions, all which decrease life expectancy. Previous speakers have talked about the somatic physical health problems, but I'd like to highlight one that is usually overlooked, but is just as toxic to life expectancy, and that's mental health. Common mental health problems are as toxic to life expectancy as smoking cigarettes. For example, somebody with chronic depression has decreased life expectancy between 6 and 10 years. And also mental health problems are very prevalent in the population. And I'll argue as well, a lot of that is under-reported and under-diagnosed and is related to liver transplantation in terms of decrease in life expectancy and a risk factor for post-operative outcomes. Now, the good news is all these things can be managed or even prevented when patients make positive changes in their health and lifestyle behaviour. So they're critically important for, in the context of liver transplantation, longer survival on the liver transplant waiting list, which can be a number of years for some patients, and long-term post-transplant survival. But I also argue, as well as survival, quality of life while on the waiting list and quality of life post-transplant. This is part of the intervention to develop this graphic to illustrate, because I think a lot of people, a lot of the time, patients confuse the difference between behaviours and outcomes. So we have the behaviours on the left. So we have dietary behaviour, free living, physical activity and exercise, so that's exercise out the supervised setting. So this can be anything from gardening, housework, just simply going for a walk. Support with abstinence from alcohol. Support with medication as agreed by you and your doctor, in other words, medication adherence. Stopping smoking and staying stopped. A lot of patients might report that they've stopped smoking, but as we all know, behaviour change is not a straight line. Some people fall off the wagon and they require support with staying stopped. And also referral for supervised exercise for people with low cardiorespiratory reserve. Now, those behaviours are related to outcome risk factors. For example, weight as an outcome, blood pressure, a whole range of blood test results, and fitness. Now, all those things as well, all these behaviours are related to the development of chronic diseases, and these in turn predict peri- and post-operative clinical outcomes. So it's illustrating, first of all, that behaviour change is the key to improving quality of life by addressing risk factors and improving the rate of chronic health conditions, which in turn predict post-transplant outcomes. So LIFT, what the LIFT philosophy is, it needs to provide a way of structuring those consultations with patients and the relatives, I think it's important to emphasise relatives because not one of us is an island. We all have those around us who support us, where we discuss options with in terms of what's best for us, and more often than not, that's our families. So LIFT needs to address a sense of I'm informed patient, so it needs to address knowledge, so a person needs to know about their condition, what they need to change, why, and the options available for them to do so. They also need the skills to do that. They need to be capable patients. I've identified the best options for me. They know what their options are and have acquired those skills. And as been emphasised in the previous talks, confidence or self-efficacy. It's not enough to have the knowledge, it's not enough to have the skills. It's having that confidence to actually enact those skills, but also deal with setbacks. Because behaviour change, like I said, is never a straight line. It's more like this, ups and downs. However, in the context of liver transplantation, there is a dearth of evidence-based health and lifestyle interventions. There's nothing that we can really take off the shelf that fits into this context. And what we want to do is design LIFT for everybody on the liver pathway, so adults being assessed for liver transplantation, those being listed for liver transplantation, and those post-liver transplantation. So some exploratory work done by the team at the Institute of Transplantation at Newcastle was data from a post-transplant clinical review. 18 months data was analysed, and substantial proportions of patients had risk factors that predict poor perioperative and post-operative outcomes. For example, almost a third were obese, 42% had high BP, and around 13% smoking. And there was lots of other variables that were looked at in terms of the amount of people who reported drinking alcohol, but that was very much self-report, and there was very minimal assessment of physical activity levels, as well as other types of behaviours. Also, a colleague of mine, Leah Avery, a health psychologist, reviewed video footage of actual interactions between professionals and patients during the liver transplant assessment process. What was noted was professionals, in terms of the liver transplant team, regularly asked about, well, do you smoke? Do you drink? How much? How often? Which is good, but they didn't engage them really in any meaningful or structured discussion on how to engage them in a decision-making process where they were informed and they can make a decision about change which is based on their preferences and arguably their need as well, because some people may not be obese, it may be blood pressure that needs to be targeted, for example. So what we did was we referenced the MRC framework for the development and evaluation of interventions and the previous exploratory work and relevant research evidence, which I'll talk about in a moment. We engaged the patients, pre- and post-operative, their relatives and the clinical team in an iterative co-design process, because what we wanted to do was find out their views and their preferences. How should the intervention be delivered, the mode of delivery? What information do you want to see in the intervention? What are your information needs? How would you like to see it structured? We also looked at the research evidence in terms of behaviour change techniques, which are from a reliable taxonomy theory linked behaviour change techniques published by Mickey et al., to show that the ones that relate to actual effective behaviour change. And also other intervention features. What else would they like to see part of this intervention? Now, the reason we engage the end users, if you like, in the intervention is that we want to maximise the likelihood that any intervention we develop is optimally acceptable and usable in that specific context. So some of the evidence-based behavioural content is from previous work, and this is shameless self-promotion. There's the 3 papers there that I was involved in publishing, but there is lots of other research evidence in this area around obesity, smoking cessation, physical activity, diet, and medication adherence that we looked at. And these were the common behaviour change techniques that emerged from a cursory examination of that. So it's around explaining the natural consequences of the behaviour to individuals. So if they don't do anything, this is what's likely to happen. BCTs around shaping knowledge. Goals and planning. feedback and monitoring. So we took that forward to develop sort of initial mock-ups of what the intervention might look like. And we took them forward, first of all, to workshops with healthcare professionals, part of the liver transplant team. 7 took part in the first workshop and 13 in the second. The feedback was, the key points for the intervention development were, we need a protocol for the accurate, reliable and valid assessment of behaviour and outcomes, which is currently not in place. So we need a bespoke database to record and monitor changes. We also asked for modularised training, face-to-face training developed by an expert in behaviour change, plus support with Fidelity of delivery post-training. I'm sure we've all attended training sessions where it is a morning or an hour here, an hour there, and we forget most of what was said, or we don't get an opportunity to practice and get feedback from the facilitator. So in this intervention we're going to be having, once somebody's been trained, is that, for example, one of the transplant team would record an interaction with a patient, and then one of us would listen to that and provide structured skills feedback, recognising again that the training component is also an intervention, and the behaviour change of the clinical team is also not like this. It also takes time. The clinical team also asks for support with explaining to patients the absolute benefit or risk reduction in outcomes if they change their behaviour. So again, reinforcing this link between a behaviour such as diet and physical activity and how that influences an outcome, which is weight. And they also ask for short educational films demonstrating the skills and the behaviours in terms of how to talk to patients using motivation and viewing techniques or brief communication techniques such as the OARS model, open questions, affirmation, reflective listening, and summarising. What did patients and relatives tell us in their workshops? Strong preferences, very, very strong preferences came out. Well, we need to understand our condition first. We need to understand what all these blood tests, all this physiological information that's given to us. What is the process? A lot of patients may not be aware of that, well, you're being assessed for transplantation. What's the next stage? What's the criteria? What are the risk factors? What do I do post-operatively? So they asked for an initial group-based educational session, which will be facilitated by a member of the liver transplant team, to address those early information needs, those burning questions that people have. And they said this to us, that I'm not really going to listen to anything about lifestyle or anything like that until I get my questions answered, that's most important to me. And then the provision of psychosocial support was described as being critical, and this is before we start talking about health and lifestyle behaviour change. So issues around mental health, finances, the social life, activities in their family. And this is a tool that we've embedded within the LIFT intervention, and you may have seen this in various contexts. I've used this a lot when I've worked in one-to-one counselling. I've used this a lot recently working with veterans, for example. So it's just asking a person that this is the things that are important for psychological well-being or psychosocial well-being. On a scale of 1 to 5, rate each one of those. And there's a space here for something else that might be important to that individual. So it's all about addressing these issues first before moving on to discussions around health and lifestyle behaviour change, specifically related to clinical outcomes in terms of the operation. Across the workshops, there was these behaviour change techniques which were seen as acceptable and could be delivered in a reasonable amount of time and wasn't overcomplicating the process. So around personalised goal setting, action planning, barrier identification, coping planning and review goals. And I'll explain what those are in a little bit more detail in a moment. Other critically important features of this, which reflects the previous presentation from the gentleman at South Tyneside, is the need to involve multi-agency working. So the need to work with the local public health, teams to provide smoke and cessation services, as well as psychological therapy services, IAPT, improving access to psychological therapies. Both of those instances, people can self-refer, or they can be referred by the coordinator. But also as well, what came out as well is let's not forget the experts by experience in this process, the charitable organisations, the third sector, because they are well placed to provide peer support and advice. It's an emotionally challenging time across the pathway. So here's a diagrammatic summary of the process, and this will be used for both identifying psychosocial needs as well as behaviour change needs related to clinical outcomes. So you have agenda setting, so it's putting the patient at the centre of the process. What do they want to achieve? What, based on their patient assessment, it may come out that, for example, that they are smokers, that they are overweight and their blood pressure is high, for example. Then some agenda setting in terms of how they're going to change their behaviour related to those outcomes that they want to change. Then providing a menu of options for change, including the external referral, like I said, to the local public health team or local IAP services for mental health support. Then an action plan. What might get in the way of them achieving their goals? Developing coping plans or if-then plans. So if they encounter a particular barrier, then I will do X. But that comes from an accurate person-centred discussion of what your likely barriers are likely to be for you as an individual. And then a regular review and patient assessment. And it could be further goal setting, depending upon whether the patient has achieved their goal or not. So here's an example of some of the graphics that can be used for agenda setting. So here we have a one around outcome states. So weight, blood test results, blood pressure, or fitness. So the idea is an accurate, a reliable and valid patient assessment would inform personalised information to populate here so that some of these outcomes are not chosen without any reason. So it adds extra relevance to why a patient may want to choose those. And then the SMART goal setting. Now this is goal setting, in my experience, is either done well or not very well. And I think it's important to emphasise in the goal setting process that it's important to set short-term, medium-term and long-term goals, and they have to be SMART. So once an outcome goal has been set that's realistic or achievable, for example, you could say to a patient something called a verbal confidence rule. You could say on a scale of 1 to 10, where 1 is not very confident, 10 is extremely confident. How confident are you can achieve this goal? If they say a 7 or above, you can safely move on. But if they say a 4, that's probably because this is not achievable and there's some discussion needs to be had maybe in terms of lowering it. And then you go through the same process related to actual behaviours that are going to be related to improve this outcome of weight. So it could be diet and physical activity, for example, and present a menu of options. And then it will be an action plan. So this involves when, where and how, including how often and with whom is important. So recognising that social support is critically important in the behaviour change process. So that could be wife, partner, family. And then coping plans, following an assessment of barriers, and then outcome and goal review. Then depending on the outcome of that, the process begins again. So conclusions and next steps. LIFT, very early stages of development, but it's very exciting. It's multi-behavioural, it's multi-agency, but also bringing in the third sector, the voluntary sector, the experts by experience. And what we ultimately hope to end up with is something that enables patients to make informed, that they are knowledgeable about their condition, what they want to change and why, and make choices for change that's based on their preferences and their values. Because there's many ways of changing diet, there's many ways of increasing physical activity, there's many ways of improving medication adherence, there's many ways of stopping smoking. The list goes on, but it's offering that choice. But more importantly, the person knows why they're engaged in those behaviours, because it's important related to an outcome, and ultimately, longer term, their outcome after surgery. But also has psychosocial functioning as a component of that, and directly asking around issues around mental health. Now, you hear the term supported self-management. This is self-management, but truly supported by the liver transplant clinical team, so patients aren't left on their own to read booklets and that sort of thing. It is facilitated and supported by the clinical team. Also, as well, a critically important part of any behaviour change programme is a robust skills development training programme for the people delivering the intervention, but with also a skills development feedback component in terms of Fidelity assessment, and that capability to signpost and refer to additional services and sources of support for patients. So following more development work, there's quite a little bit more to do, including a systematic review that we currently started. We plan to do a feasibility study in the very near future. Thank you for your kind attention.
Top Med Talk.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher, or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. Have a look, ebpom.org/meetings.